Welcome back and thank you for staying with KTN Prime. As hinted a little bit earlier on, right now we're focusing on the state of healthcare in the country, the UHC implementation, SHA rollout, and other issues that are bedeviling the health sector in the country. We have the Health Cabinet Secretary in studio. She needs no introduction. Dr. Deborah Barasa is joining us. Thank you so much for your time. Let's get to the issues that Kenyans want addressed. It's been over 2 months since SHA was rolled out in the country. Unfortunately, it has been characterized by numerous challenges. Others call it teething problems, some systemic challenges here and there, public confusion, among other issues. It would be proper to begin on this note in terms of what the ministry is doing to address the challenges that have been called out time and time again ever since SHA was rolled out.
Yes, thank you. Thank you so much. And yes, maybe we should just start from the beginning so that everyone understands why Taifa Care, why universal health coverage. And this really comes from the, SDG 3, that's the Sustainable Development Goal 3, the Vision 2030, and the bottom-up economic transformation agenda. This is an agenda, again, it was something that has been tried frequently in various countries, some with great and marvelous success. Actually, recently I was in Rwanda and I saw the great work that they're doing. They call it community health insurance, and indeed there is affordable, accessible, quality care. Now, in Kenya, why are we moving this way? First of all, let us look at the demand. Yeah? There's a rising population, rising communicable, non-communicable diseases. The budget constraints are there. The budget for health is really on the rise at county level, at national level, and yet we are in a tight fiscal space. And let's not forget that the donor funds are dwindling. So as a ministry, we need to come up with sustainable solutions. We need to have health financing system that is of domestic in nature. We cannot always rely on external factors and other governments. Governments come in with policies, they come in with agenda. We cannot be over-dependent on other governments to fund us. And so those are really critical as we look at our own health financing system as Kenya. And really, even when you look at, we've just celebrated the World AIDS Day. HIV has been there with us for more than 40 years. Previously, it was under an emergency plan fund, but currently, the donors also want us to be self-reliant. They need us to be self-sufficient. Okay. So all along, we are being called upon to be self-reliant, and that is why the health financing comes in, where the rich and the poor, the young, the old, the healthy, the sick are contributing, and those who are vulnerable, again, can access the very same health care that each one of us is accessing. So there is the health financing component, but again, we look at the whole system in totality, where we want to improve the human resource for health. We want to improve the health products as the essential medicines and other products and technologies, and equally have a digital health platform. This will ensure efficiency and effectiveness of the system, transparency as well, and then we can be able to address issues of corruption in this system. So we rolled it out 1st October. Now what's happening, we have more than 16 million Kenyans who have been registered under the Social Health Authority. Among these, 33% were transitioned from NHIF, and we have a whole 66% of them, which is more than 10 million, who are again newly registered under SHA. Yeah. So this tells us that people are sensitized, people are registering, and there's improved coverage in terms of population, in terms of geographic distribution in Kenya. And now we are moving towards accessible services for Kenyans. And even as you look at the healthcare facilities, we are onboarding even more healthcare facilities, and gradually we believe that we'll be moving towards that accessible care. So when we will look at what you had asked, the challenges, yes, at the beginning we had system challenges, administrative challenges, and again the registration when you're moving to, from registration to means testing. And so we have come up with strategies to ensure that we are addressing the communication component. And then the law, we are using data, it's data driven. We have a digital health platform. We can be able to map out and identify which counties are having low uptake, which ones are having high uptake, and there where there's low uptake, then we have a rapid response interventions where we are pouring out, our SHA team, ICT, the parliamentarians, the politicians, etc., to ensure that there's rapid uptake of SHA in these regions. So there is a lot that is ongoing. Again, we look at the communication component. As I have said, we are really expanding. We have 16 million Kenyans who are registered. But in this, we're expecting that if we incorporate dependents, because currently we have only more 2.5 million dependents within the system. So we want to incorporate more dependents, and in this we are seeing we can forecast that we'll reach up to around 30 to 40 million if we have the dependents on board. So we are working with the Ministry of Education to ensure that they are on board. Another highlight is the elderly, where we are having less than 5% of them being onboarded. And this is really worrying because, these are the geriatric, the old age group. They are likely to suffer from conditions like diabetes, hypertension, arthritis, etc. And so we are also reaching out to ensure that we are onboarding the same. So we have sensitized the politicians, especially the MPs, the senators. We are meeting the governors routinely and telling them the critical component of social health authority and looking at the facility improvement fund, because what this looks into is ensuring that the resources are brought to the facility. So based on the number of patients that you have registered and you are seeing within a facility, then SHA is able to send you the money, and then now you can be able to capacitate your facility, and that vicious cycle continues. So we'll see health products reaching the last mile at the facility level, and we are also envisioning that the very same resources, as they continue building up, they should be able to capacitate and help in matters human resource and help in matters building capacity, equipping the facilities. Okay. So we hope to really work together with them counties to improve that.
All right, I just want to take you back to what you mentioned. I mean, we did mark World AIDS Day just a few days ago, but then under the rollout of SHA, HIV is categorized as a pandemic and not a chronic illness. Doesn't that discriminate HIV patients? I mean, 1.4 million people are living with HIV.
Absolutely, we are not going to discriminate against HIV patients. First of all, HIV involves, it's a systemic illness. So it involves various organs. It causes opportunistic infections, etc. At community health level, we are saying we'll be able to support in the diagnosis and prevention of HIV. Right now, the move is always towards prevention because of the drop in the numbers. Again, you'll come at primary health care, where testing can occur, and then we can also diagnose other communicable and non-communicable diseases and start treatment. Now, at primary health care level, you can also access ARVs. Yeah? So we are saying that we are integrating, we are incorporating the HIV programs within the primary health care, because we don't want this silo kind of a system. We want a comprehensive, consolidated system. And when we move at other levels of care, when patients have complications, they can also, under the Social Health Insurance Fund, be able to access treatment for any complications. So we are working to synergize our efforts with the teams, the NASCOP team, the funders of HIV program, to ensure that it is really complementary, it's really an integrated response, because currently what we are seeing in HIV cases is that they are well, maybe the viral load is reduced, the patient is stable, but they're having non-communicable diseases like hypertension, diabetes, etc. So how do you integrate and have a comprehensive, everything under one roof when the patient comes in? So those are discussions that are ongoing, and we want to assure the people living with HIV that we will work and ensure that the management, the services are comprehensive and are integrated within the system.
Speaking of services, there have been challenges in the digital claims processing systems. Have we reverted back to the NHIF systems? I'm sure you've seen that question time and time again. And equally, tell us about how you've addressed this unpaid claims. What's the status of this claim so far?
Wonderful, wonderful. Yeah, we've done a lot. First of all, let me start with the digital health platform. A lot has gone into this.
Okay.
I mean, you can imagine within, let's say, less than 100 days, we've been able to develop the minimum viable products so that we are having the portal for registration, we are having, the patient encounter, and again, we are having the claims and other systems within this digital health. Ultimately, we are envisioning to have, the KEMSA, the community health information system, disease surveillance, health worker registry. We want to have health facility registry, everything within one roof, okay? Even the regulations like the Pharmacy and Poisons Board, so that now medications are of quality and are of standard. We don't want counterfeit medications in Kenya. We want to monitor even the procurement. And as I said, even in Rwanda, you can see that drugs that were 10 times more have drastically dropped because of standardizing this and having visibility and transparency when it comes to matters procurement. So the digital health platform is the way to go for Kenya. Okay. If we want to fight corruption, if we want to minimize the cost of medication, if we want to have efficient, effective services, and if we want to have transparency and among others. Now, when the claims have been there, but let us talk about the pre-authorization. Turnaround time has been 72 hours. People are impressed with this. We had a small challenge. We've been able to mobilize some staff within, and also we are capacitating at facility level to ensure that the healthcare workers are also able to pick up and also support in the pre-authorization, so that the work at the social health authority level is really to ensure and monitor that we are not having any leakage of resources. We have had claims. We've been able to disperse 1.3. We've had 1.3
billion?
1.3 billion, okay. Yes. We've had 117,000 claims, more than that. And half of it have been paid, that is the 1.3 billion. And we are envisioning the 64,000 claims that are remaining. We hope that we should be able to pay hopefully by end of December or mid-January. That way we want to win the trust of Kenyans by ensuring that we are paying. And what is of interest is when you look at even the renal cases, in September, we had more than 36,000 sessions under NHIF, but now we are having more than 40,000 sessions under the Social Health Authority. Equally for oncology cases, where we previously had 4,000 to 6,000 sessions. Now we are having up to 16,000 sessions. So what we are seeing is the oncology cases, the cancer cases are onboarding, the renal cases are onboarding. Maternity, again, we need to sensitize even more because it's slightly lower, but I believe that when we sensitize the community, our mothers, then will be able to ensure that they are able to access these services. Bearing in mind that while Linda Mama was taking care of the mother alone, what social health authority envisions and Taifa Care is to take care of the whole family. So the mother, during antenatal care, delivery, after delivery, even for her child who has been delivered, and during the vaccination period, and the whole family, so the husband and other children, the whole household is going to benefit from the social health authority, because it's not just about the service, but it's about paying for the premiums for the mother and the household. So we are really encouraging Kenyans to register so that they can be able to access the services.
Well, it's a good thing you touched on the issue of chronic diseases. I mean, cancer, dialysis patients and all that. But they seem to be facing the most challenges, especially dialysis and cancer patients. We have seen several healthcare providers, including dialysis centers and private hospitals, express concerns about onboarding to SHIF, citing unpaid debts from the previous NHIS system. Away from that, we've equally seen patients decry the fact that once the medical cover is depleted, then what next? Maybe you can help us understand that.
Yes. So with the dialysis, I remember when we were, transitioning, some of the patients were not well informed about the transition process. And so before they onboarded, again, it was a challenge. But when we look at the statistics and we look at the tangible data, we are seeing that patients have onboarded and dialysis is ongoing. The sessions are the same. Actually, for dialysis, it's even better because we are having pre-transplant services, we are having transplant services for the donor as well as the recipient, and the post-transplant, including the medications that these patients are going to use. And when you look at renal care, it actually starts at the community level, where again we are strengthening the prevention practices at primary healthcare level, again where we are also diagnosing hypertension, diabetes, doing urine tests, etc. So it's all about really continuously strengthening the system. And what we are doing is engaging first at community level, second with the support group. This includes the renal cases, the dialysis care, the patients on dialysis, the patients with chronic kidney disease, meeting them, engaging, understanding what they need. We had a meeting with the cancer patients, and they raised their grievances about the second, some of the medicine, the chemotherapy that they're using. And again, we met the oncologists in various platforms and the big pharmas. And so we are engaging, we are picking best practices from all over countries like Rwanda, and even across the globe, outside of Africa, other continents, to ensure that what we are offering Kenyans is quality. And really, this is about, again, at times the challenge is really breaking the middlemen and ensuring that the cost of medications are going down, especially for chemotherapy medications that are really high. So with those strategies, and as we continue engaging them, and again, what I would really want to say is after 1 year, we are reviewing the health benefit package. And even at this time as we are speaking, we are already mobilizing a committee to review the health benefit package. Okay. And when they are reviewing this package, anything that needs critical intervention will be acted upon, including the challenges that our dialysis and cancer patients are facing.
Because that's not the only issue. I mean, we have packages, issues such as hearing aids that are only issued once in a lifetime, wheelchairs and the likes. So yes. What happens,
Brilliant. I love that question. And you know why I like it? It's because when we were developing the benefit package, what were we looking into? First of all, what infections are prevalent? What is causing death? And what is causing catastrophic expenditure? In that people have to sell their land, everything in order to get the services. So that is how we categorized, based on the prevalence, based on our NHIF data, who is accessing what services, at what cost, what is depleting the funds, and all that. So a lot of brains and interventions went into development of this health benefit package. Yet again, for customer delight and customer satisfaction, we need to go back and review the benefit package. So we are getting the concerns that are raised in terms of devices. The dentists again are also raising their concerns, among others. So what we are saying, this is just the beginning. It's just 100 days, and this is affordable, accessible, quality care for all Kenyans. So just give us time as we continue tweaking and ensuring that everyone is able to access.
Is there a time frame, if I may ask, just briefly, is there a time frame on?
Now, when we talk about continuous quality improvement.
Okay, say no more.
Yes.
The Kenya Union of Clinical Officers accused the Social Health Authority Board of failing to register at least 1,000 healthcare facilities operated by clinicians. It would be unfortunate since, according to the union, they say that they offer primary healthcare services across the country and had been registered under the defunct NHIF. Why were clinical officers excluded from providing these essential services?
Clinical officers were not excluded. It is the way we conduct facility assessment.
Okay.
We conduct, before one gets the license, it's normally under the Kenya Medical Practitioners and Dentists Board. And we understand it is the system we have found present. Ideally, we should have a quality authority to conduct assessment of facilities, whether it's for the nurses, the clinical officers, the doctors. That way we don't appear to be discriminatory or there's conflict of interest. We'll be addressing that through the quality of care bill, which we hope that it will turn out to be an act and will be able to streamline and ensure that we have a professional body and we have this quality authority building. So I know we've had various engagements with the clinical officers. What we have told them in the meeting, and I believe it has come out, is that there will be no costs as they get empaneled, because when they're being assessed in the facility, because they've already paid in the clinical officer. They will be assessed and then empaneled at no cost, because they have already paid. Because this is the transition period as we really try to streamline and understand. And this is again based on best practices from across the globe. It's not just about Kenya, but what do they do about the professional bodies? What do they do about quality of care in order to access and show that there's continuous quality improvement within the facilities? And so even for the clinical officers, the nurses, etc., what we are saying, let's come on board, let us deliberate, let us engage. We are all healthcare professions. This is a critical time for the Ministry of Health, because it's a paradigm shift and we all need to be on board, even as we try to support the nation to have affordable, accessible.
So even as we continue through this journey towards achieving UHC, Taifa Care, whichever one may like to call it, do you think SHA is the missing piece? Is it the silver bullet needed?
Absolutely. And you see, best practices from across the globe. Previously, NHIF was biased. Only 20% of our population could access services, and those are employed and few people who could afford. Now we are looking at affordable, accessible, quality services, leaving no one behind. So I think it is really critical as you look at our Health Act. Health is a right for all Kenyans in our constitution, but we have failed to address that by having NHIF only, supporting service for those who are able, those who are privileged. The world is going into UHC. We are having so many countries right now, rolling out UHC, and we are trying also to be, a best practice. And we are very privileged to have the political will from the highest office in the land to support us during this time. So we need to seize the moment and really try and complement and synergize our efforts so that we can deliver this. It is difficult at times, yes. It is ambitious indeed, but definitely it is something that we need to try and ensure that it works. That way everyone can access care. I always say, anytime you can lose your job when you get to your 50s, 60s, you get chronic diseases, arthritis, diabetes, and that is when you don't have a job, you're retired. Then what happens, So this is really a safe home, a coverage for all the Kenyans in our walks of life. And so we should look like we are advocating for it, we should support it, and we should do as much as possible to ensure that it's working, because it has worked in other countries and people have benefited. So we should follow through.
Okay, just taking one or two questions from our viewers. Yes. Someone wants to know, at what point did we transition to Taifa Care? And equally, they're interested in what the government is doing to bridge the budgetary constraints in order to sort out some of the challenges being faced.
Yeah, so for transitioning to Taifa Care, yes, the rollout of SHA, as I said, Taifa Care is the overall. It's the universal health coverage. So community health level, the primary health care, all levels of care, looking at the health products, looking at human resource for health, and an enabling environment, which is the digital health platform. So that whole system, the cover is really Taifa Care. Yes, there have been budget constraints, but we are lucky because actually from the claims that we've had, from what we've been able to accrue so far is around 6.1 billion. We've paid the primary health care fund 1.3 billion. Again, the claims, NHIF claims, 1.3, Linda Mama 2 billion, okay? So if and the average amount through means testing is around 575 Kenya shillings, which really is affordable for most Kenyans. Yeah, but again, if the extremely, the poor, the vulnerable, the needy, then they undergo the means testing, and then we can support them through the various measures so that they also receive their premiums. And so, looking at that figure, then we know that if we are able to onboard Kenyans, it's sustainable.
Just one more question from our viewer. They seem to be questioning how means testing, especially for the unemployed persons, is being conducted. Case in point, I was hosting one of the doctors from the union, and last year they poked holes into the means testing, mentioning that if you come to my household and find a chicken and a motorbike, and then 1 year later, I've slaughtered the chicken and my motorbike got into an accident, am I still supposed to pay the amount that was prescribed when I had those two things under my belt?
Yes, yes, that's a brilliant question. Yeah. So what we do is we have a contesting mechanism.
Okay.
So in case you are not comfortable, and strangely enough, I think we've had just 2% of people contest.
So barely.
Yeah, we're not having any.
Okay.
So.
And
we were waiting for the contest so that we can see really how's the system. And as I said, the average means testing is 575 Kenyan shillings.
Yeah.
So people are onboarding. Yeah.
Okay. We will continue with this conversation, CS, a bit later. And of course, just to our viewers, there is no way you can get to UHC without thinking of solving issues affecting welfare of those who are treated, So we will be talking about that a bit later. But first, let's take the break.